Hey, Josh. Josh, can you hear me?
Yeah, I can. Can you hear me okay?
Yep. Perfect. Hey, so you're going to have to explain to me the sharing with my talk.
I've already got your sharing, so, or I've got you focused here. Let me see. At the bottom of the screen, there's a share button, or the bottom of this window.
Yep. Okay.
You click on that. There should be an option to share the screen or to share a file if you want to do it that way.
Yeah, let me see if I can. Whiteboard, Google Chrome, PowerPoint. Let me see if this is share. Okay. Does that do it?
Yep.
Okay. Let me just make sure I can see it as well. Is that full size for you guys?
No, I'm still seeing the slides on the side.
Okay.
There it goes.
Does that work?
Yeah. Can you hear us in Kampala?
Yep, we can hear you.
Great.
We can hear you very well. And all right. Yep.
Okay. Good afternoon. What time is it there?
It's 4 p.m.
Okay. It's quite early here. Okay. So I can start by giving a lecture about kidney cancer, and specifically about surgical management of kind of localized or advanced metastatic cancer. There's a lot of parts to this, and we can maybe give a talk for about a half hour, and then you guys want to ask questions or interrupt me at any point, and we can discuss things. Okay?
Yeah.
So I'm one of the urologic surgeons up here in Salt Lake City at the University of Utah. We have a cancer hospital up here called the Huntsman Cancer Hospital, and I work up there and only do cancer for urology at this point. So, all right. Kind of a little bit of an outline. Let's see how much we get through. But my idea was we talk a little bit about the epidemiology of renal cell, and then we can talk a little bit about some sort of hot topics of kidney cancer surgery, and that is you know, do you need to do an adrenalectomy, adjacent organ resection, issues related to lymphadenectomy, and then if we have some time, we can talk about IVC thrombectomies and neoadjuvant or adjuvant therapy, and the cytoreductive nephrectomy. So in the United States, kind of our breakdown of, you know, cases, cancer cases. Can you guys see my arrow if I move that around?
Yep.
Okay. So, you know, and obviously this is going to be different where you guys are, but obviously the prostate cancer is the largest for men. Obviously the urology takes a lot in the top 10. There's bladder cancer, and then about 5% of all cases, about 44,000 per year for kidney cancer. For female, it's a little bit lower. The kidney cancer rates are around 30,000 a year. And obviously there, breast cancer and lung cancer are predominant. The other thing about kidney cancer, it's interesting, is that we do know that in the States, about 30% of people who present with kidney cancer will already have metastatic disease. And another 30% of people that the people that are treated for kidney cancer, 30% of those patients will go on and develop metastatic disease. So an aggressive disease. If you break down the subtypes of kidney cancer, and it's important to think of it as it's not one disease. There's different types of cell types, and they act differently. The majority of them are clear cell renal cell carcinoma, about 75%. But there is a smattering, about 25%. There's a 16% are a papillary, type 1 and 2, often multifocal. 7% are chromophobe, which tend to be a little bit less aggressive, although can grow quite large. And then another 2% have some very aggressive features. There is medullary sponge kidney, or renal cell. There's a collecting duct tumor and a translocation type of tumor. The medullary and translocation are mainly in younger patients. Collecting duct tumors often tend to be sort of middle-aged. And all of these can de-differentiate into a sarcomatoid variant, which tends to be very aggressive. In all the textbooks, you'll see what they describe as the classic triad of renal cell carcinoma, which is people have flank pain, hematuria, and a palpable mass. It doesn't happen very often anymore. We don't see it that much. About 70% of our renal cell carcinomas are now discovered incidentally because somebody gets a CT scan or an ultrasound. Classically, it's also described that you can diagnose these with new onset varicoceles in a male. Obviously, left greater than right because the left gonadal drains into the left renal vein, and the right side drains into the vena cava. There are some interesting facts about renal cell carcinoma, in that it can often present with other sort of other disease types or symptoms. It's very common that they have anemia, thrombocytosis, or erythrocytosis. There's also a well-known syndrome called Stauffer's syndrome, and people will often have hepatic dysfunction, so elevated LFTs. And most of these, as soon as you do the nephrectomy, go away. Upwards of 20% of people will have fever or have some weight loss, usually a poor sign. And then very interestingly, we'll occasionally see paraneoplastic syndromes or rheumatologic disorders. And those paraneoplastic syndromes can be related to excessive parathyroid hormone secretion, or there can be changes in insulin and glucagon secretion. In terms of rheumatologic disorders, they're fairly rare. You can have secondary amyloidosis. I've seen a couple cases of people presenting with polymyalgia rheumatica, and it's very rare. It doesn't respond to steroids, but interestingly, it responds to the nephrectomy. This is our current staging for renal cell carcinoma, and not to complicate things, but our essentially what you have is you have the T1 group, which is which is tumors 7 centimeters or less. T1A is 4 or less, and T1B is from 4 to 7 centimeters. In general, most of these, especially the smaller ones, are treated in the United States with a partial nephrectomy. As you get bigger, somewhere between 5 and 7 centimeters, you then sort of have a transition where you treat most of these people with a radical nephrectomy. Once you're over 7 centimeters, you end up in the T2 category. They do break it down between 7 and 10 and greater than 10 centimeters based on survival data. Sorry, I'll go back there. And then what we're going to talk a little bit about is T3 disease, which is essentially either the tumor extends into the major veins, so the renal vein or the IVC, or stays within the capsule, or it extends, or it extends into the adrenal gland, which is then T4 disease. Okay, there's some breakdown in terms of renal vein thrombus extension. If we call it a T3A, if it essentially invades locally, but not beyond Gerota's fascia, or extends in the renal vein. If it extends into the inferior vena cava, but doesn't go above the diaphragm, that's a T3B lesion. And if it extends above the diaphragm into the, so above the diaphragm into the heart, or to the wall of the vein, that is considered a T3C lesion. All right, how about talking about adrenalectomy and adjacent organ resection? I think historically we've always talked about that the adrenal gland's part and parcel of the kidney, and that when you do a nephrectomy, you take the adrenal gland out. That has changed. We generally don't do that in these days. But there are times when we do take the adrenal gland out, and those are when you have direct extension of the kidney cancer into the adrenal gland, okay, or a discontinuous lesion, which may be a metastatic lesion. If it does directly invade into the adrenal gland, it's considered T4 disease and is a poor prognostic marker. In general, these lesions tend to be quite big. The median tumor size is somewhere around 11 centimeters. There's a study that looked at what the incidence is, and it's quite low. Obviously, in this study here, of a total of 2,500 kidney cancers, only about 1.5% had adrenal gland invasion. Almost 40% had positive margins, which also shows you it's fairly aggressive locally. And interestingly, it's not the adrenal gland, but rather the liver that was the most common organ that had invasion. And unfortunately, if you do have adjacent organ invasion, the reality is life expectancy is not great. So here, the median time from resection to death was about 11 months. And obviously, a positive surgical margin was associated with recurrence. How about doing a lymphadenectomy? So doing the nephrectomy and then removing lymph nodes. So there's been in the last, I would say the last 5 to 10 years in the United States and Europe, a lot of debate about this. Some people feel very strongly that every time you do a nephrectomy, you should do a lymphadenectomy. And there's also a very strong kind of bias from some people that say it's not worth it. So there has been a European trial that was performed over a longer period of time in the late 80s and 90s. And that data took a while to get out, but essentially what it showed was that there was really no, whether you did a lymphadenectomy or not, didn't matter in terms of progression-free survival. The couple of the issues, one, this trial essentially had, if you had a right-sided tumor, you did a paracaval and an intra-aortic node dissection. And if you did a left-sided tumor, you did a periaortic and a preaortic. You did not do the intra-aortic nodes. Lots of problems that people have pointed out, essentially that the incidence of having a node-positive disease was quite low. And so that underpowered the study. And the other thing is that the majority of patients in the study were low risk, which is what we see here in the States and in Europe. They did not present the histologic subtype. We didn't know exactly the template for most of these surgeons, and the amount of numbers that were, nodes that were resected and numbers were positive were not known. So a lot of limitations and a lot of controversy for this study. That said, there have been a couple other studies that have tried to kind of retrospectively go look back at what's the implication for a lymphadenectomy in renal cell carcinoma. And essentially, there's been no study so far that shows that there's an improvement in survival. So generally, I would say that the most people in the United States will not get a lymph node dissection at the same time as a nephrectomy or a partial nephrectomy. So how do you identify patients at risk for renal cell carcinoma or lymph node involvement? And the reality is that it's an arbitrary marker. Essentially, any lymph node that's greater than 1 centimeter is considered abnormal. That's sort of the cutoff by the radiologist. And the caveat, of course, is that about 60% of these cases, so if a node is enlarged on CT scan, 60% of the time it's actually just inflammatory and benign. So it is not necessarily kidney cancer. So essentially, in terms of node disease, or if somebody has nodal involvement, it's an independent marker. It's obviously associated with someone who will probably develop metastatic disease. If you have lymph node involvement, your cancer-specific survival is going to be on the lower end of things. Your 5-year survival upwards, maybe up to 40%. And usually, it means that somebody has a cold disease already at the time of the nephrectomy. And the median time to progression in a lot of these cases was only about 4 to 6 months, okay? So the bottom line is this, that there is probably a small subset of people that will benefit from a lymphadenectomy. The problem is we don't exactly know who that is. So what we usually say is that if someone has an enlarged lymph node at the time of nephrectomy, we will actually do a lymphadenectomy, and given the fact that it's probably 60% are benign, but it may be metastatic and may be a marker for closer follow-up because they may advance shortly thereafter. And there's also some data to suggest that maybe those patients are the patients who might benefit from adjuvant therapy. What that adjuvant therapy is, we don't really know. That said, even though most of the studies will show that there's no change in the complication rate from lymphadenectomies, I think for a simple lymphadenectomy, yes, that's true. But if you start getting large, bulky lymph nodes, then obviously the complication rate is going to be higher. So Who's going to benefit? I think, that's very unclear. I think that, it's probably an issue of if you establish that there are metastatic lesions in the lymph nodes, then you have the pathologic diagnosis, then the reality is you can at least tell those patients that most likely they will progress, and they need probably closer follow-up. And I think the one caveat to that is there's always a small subset that have a long-term survival rate after lymphadenectomy, and that's critical to choose your patients. All right, so how about IVC thrombectomies? You guys see many patients that present with disease in their renal vein or in their inferior vena cava?
Yes, sometimes.
Okay. So this could be a talk that we could talk a whole hour on, and I'll give a kind of an overview of it, how we manage things. Okay. So about this sort of historically we've said 10 to 25% of patients will present with a vein thrombus. It's lower than that. Often in the specimen, you can find it, the pathologist can find a little bit of vein invasion, and we don't really count that as a significant vein invasion. But obviously, patients can show up with very, very severe symptoms. They can have bilateral lower extremity edema, especially if they include their inferior vena cava. They often show up with a history of pulmonary embolism. And then obviously they can have significant liver dysfunction with ascites. They can have a caput medusa. They can develop a acute liver problem and obstruction of their portal vein. The median survival, obviously, if left untreated, is very, very poor. Less than a third of them will survive, past six to 12 months. Now, interestingly, if you have somebody that has a vein thrombus, they actually, even someone who has a vein thrombus that goes up into the right atrium, if they don't have metastatic disease, their survival is quite good if you can remove this tumor thrombus in the mass. And if they don't have metastatic disease, M0, their 1-year survival rate is about 90%, and about half of them are alive at 5 years. Unfortunately, a lot of these patients do have metastatic disease at the time of surgery, and if they do that, their survivorship is obviously a lot less, and about 60% at 1 year. And I think this is a little overgenerous. That their 5-year survival is about 50%. It's lower than those without metastatic disease. Okay, another important factor about this is that if patients show up with a vein thrombus, one of the things that can happen quick is that these thrombi can grow very rapidly. And we usually recommend that they have either an MRI or a CT scan within 1 to 2 weeks of surgery. We've seen some rapid growths of these vein thrombi, sometimes within about 10 days of diagnosis. So I've seen a case where it was about 2 centimeters into the IVC, and 10 days later, it was in the right atrium. So it's important to make sure that this is looked at closely within surgery. Okay.
Dr. Chris.
Yes.
Hello.
Yep.
We are our computer is about to some technical problem. We are going to ask you to pause a little bit and then we come back online. We
Okay.
are going to start in a short time.
Okay.
Yes. All right. We shall be back in a few minutes. Yeah, after. You going up? Is it the one restarting or we can go on? All right, we can continue.
Okay. All right. Okay, can you see this diagram?
Yep.
Okay, so this is sort of the basic schematic of how we, stage tumor thrombi. And, the majority of them recognize that the majority of them are still below the diaphragm. Only about 1% to 2% of them do go up in the atrium. And there's different kind of staging systems, but essentially, the way to think about it is you can have renal vein only, okay, and then you can a level 1 would be somewhere below 2 centimeters up the IVC. A level 2 goes up to the hepatics, but not beyond the hepatics, and a level 3 goes up to the diaphragm, but not diaphragm, and level 4 would be above the diaphragm into the superior, the supradiaphragmatic IVC or into the right atrium. These surgeries are not simple. They often are quite difficult. There can be a lot of blood loss, and a lot of that is related to collateral vessel flow. And it's amazing how patients will adapt to a complete occlusion of their IVC, and through these hemiazygous or through Babson's plexus, they will develop a significant amount of dilated veins. All right, one of the controversies in the United States is whether or not you anticoagulate these patients. And I think that the consensus is that you obviously take them to surgery as fast as you can. But if you have to wait, then you should consider anticoagulation if they've had a recent blood clot or pulmonary embolus, or if they have near or complete occlusion of the IVC by the tumor thrombus, or if they have a large amount of bland thrombus in addition to the tumor thrombus. And so generally what you see is that from the renal vein and above, the tumor will be tumor thrombus. And the tumor rarely grows inferiorly. So below the renal hilum, the majority of clot that you see or thrombus you see will be bland thrombus. And it's very different than tumor thrombus in the sense that you can't resect it from the vein. It's often very adherent, and it has a very fibrous feel to it as opposed to the tumor thrombus, which is very, very soft. Obviously, if you put somebody on anticoagulation, you hold it prior to surgery. And something that's been done a fair amount previously is that people would often place an inferior vena cava filter. Most of us that do this case a lot would not recommend that's done, as the complexity of the surgery can go up, especially if they accidentally put the filter in the thrombus or the tumor grows up into the filter. And getting the filter out intraoperatively is extremely difficult. In terms of kind of intraoperatively, what you do, you can use a esophageal echo, and essentially what you can do is you can look at the thrombus and visualize it during the operation. This is nice to make sure that you've cleared out the inferior vena cava from tumor, and also watch it for the possibility that while you're manipulating the kidney, there are times when the tumor will release and end up going into the heart.
Chris, it looks like their connection dropped off.
Oh yeah, I just saw that too. I couldn't, when you stepped away, I couldn't hear him either.
Yeah, Job is the one sitting up front, and he got up. Looks like he was trying to fix something, and then.
Yeah. No, they were having some problems.
Okay.
Essentially, there's some debate about whether or not you should anticoagulate patients prior to the surgery. And the general consensus is that you obviously need to take them to surgery as soon as possible. But if there's a wait, then you can consider anticoagulation. For patients that have had a DVT or a pulmonary embolus, or if they have a significant amount of bland thrombus or complete or near occlusive tumor thrombus. And obviously that anticoagulation needs to be stopped 24 hours prior to surgery. And it's recommended that you do not use an IVC filter. There's any, as the tumor thrombus can grow up into the IVC filter and make the subsequent surgery a lot more difficult. I mentioned intraoperatively what you can do to view the thrombus. There's two reasons to do that. The way to do it is with a transesophageal echocardiography, and it works quite well to visualize the tumor. You can see the picture on the right side. It can help visualize what's in the inferior vena cava and also help visualize when it's removed. The other thing that can help is while intraoperatively you're manipulating the renal mass, I can also check and see if some of the tumor thrombus breaks off, and that can happen. The risk of embolization is quite low, around 2% intraoperatively. But if somebody basically embolizes a large portion of that tumor thrombus, the chance of them dying on the table is very high, about 75%. Okay. In terms of removing the various tumors, if the tumor is below the liver in general, you can just clamp the clamp just below the liver, and you can remove the tumor safely. If it goes above the liver, again, you can clamp the inferior vena cava above the liver, and then remove the mass. If it goes into the heart, obviously then you're talking about getting your cardiothoracic surgeons involved to help put the patient on bypass. There's another group of patients though, especially those that are level 3 or sort of up into the liver or up to the diaphragm, where if you clamp the inferior vena cava, they are unable to tolerate the change in pressure. And if that's the case, and they get very hypotensive, then you have to put the patient on veno-veno bypass or full bypass. So again, for the, most of the small, this would be considered a level 1, right? Here it's a left-sided thrombus in the left renal vein here. We always talk about the first thing you do in this operation is not take care of the thrombus, but do an early ligation of the renal artery. In this picture, they're trying to show where the arrow is, where the left renal artery is, and you ligate that first. Obviously, if there's a right-sided tumor, then you would go intra-aortic caval first to ligate that artery first. And in this says just for level 1, but in all cases, the first thing you want to do is get to the artery. If it's a level 2, like shown here, so you can take down some of the short hepatics here, these branches off the caudate lobe, and then essentially what you need to do is get control of the upper portion of the vena cava, the lower portion, and the contralateral renal vein over here. And then this is the if it's level 3, a couple things you can do. You can rotate, you can mobilize the liver and get access to the intrahepatic liver. And then obviously here you need to get control of your inferior IVC and your contralateral vein. And the other thing you can do is not necessarily mobilize the liver, but you can clamp above the liver but below the diaphragm. And then obviously the last thing is if it's in the heart, then you're going to need to have the CT surgeons come and put the patient on cardiopulmonary bypass. The last thing to talk about for these big cases are what happens if you narrow the inferior vena cava during the surgery. In general, the feeling is that as long as the inferior vena cava still has about 50% of its size, you do not need to do anything with the inferior vena cava. So very few of these patients actually need reconstruction. Most of these tumor masses do not invade into the vein itself, so you do not need to resect a large portion of the vein, okay? This little schematic shows a little bit about how to deal with various thrombi situations, especially in the situation where you have either tumor thrombus or bland thrombus. And remember that the tumor thrombus rarely grows inferiorly. It almost always goes upwards. And if you have thrombus below the renal hilum, most of the time that thrombus is bland thrombus, okay? And you can't take it out. Most of the time it's very fibrous and adherent to the walls of the vena cava. So obviously here would be what they call group A, which would be there's no occlusion, no associated distal thrombus, and essentially you just close the side wall of the vena cava. In this kind of group B, which doesn't happen very often, where there's kind of a break between the tumor thrombus up here and the bland thrombus, so you'll leave the inferior vena cava intact, okay? But most people recommend getting a filter placed or putting the patient on long-term anticoagulation in the event that they would have propagation of that thrombus. And then there's a group C, which is basically you have partial occlusion by the tumor thrombus, but you have associated bland thrombus. And there, in those kind of scenarios, what you want to do is there's no flow from down below. You can ligate the inferior vena cava. These patients develop collateral flow quite rapidly, and occasionally they'll have some bilateral leg swelling for a while, but most of that will go away with time. And then finally, there is this rare circumstance where you have a tumor thrombus that grows, most of it grows superiorly, but a small portion goes inferiorly. In these cases, what you want to do is essentially you remove the tumor thrombus, keep the continuity of the other vein, but then basically just transect the entire vena cava. Complication rates are obviously can be quite high. It depends on how you label a complication. But you know, I would tell you somewhere between 50 and 100% of people will have some sort of complication afterwards. The 30-day mortality rates are, you know, depending on what level thrombus you're doing, somewhere between, you know, I would say 1 to 5%. Okay, and the biggest risks are obviously if the patient has a poor performance status, they're very ill before surgery, and very malnourished. So just a quick summary. We always say planning starts before surgery, good patient selection, and you do imaging very close to the time of surgery within a week or two. And very important to do early ligation of the artery and use some modality to image the thrombus during surgery. Okay. You know what I think from a time standpoint, if you guys want questions and we can talk about things, maybe I should probably hold off on these last portions, and then we can, you know, answer any questions, or we could talk a little bit about what your needs are and what you're looking for. Does that sound reasonable?
Yep. Yes. Right. Do you have any questions? Any questions?
Who's in the room? Can you introduce who?
So we have residents,
Okay.
residents, and then we have Miss Nasanga. She's a senior urologist.
Okay.
Yes, and a few new young urologists around.
Okay. And you guys are all in Kampala, right?
Yes. Yes.
Which hospital is it?
It's Mulago Hospital.
Okay.
Yes.
I'm gonna tell you something that's believe it or not, I've been in that hospital. I will tell you, my brother was born in your hospital. My father worked there in 1967 and 1969 with the National Health Service, and I moved to Uganda when I was 3 months old, and my brother was born in Mulago Hospital. So,
yeah,
but I don't remember.
yeah.
So,
I have one question though.
sure.
So when you're doing the thrombectomy, do you need a vascular surgeon around, or you do it yourself? And
We do it ourselves unless we are going to replace the inferior vena cava or put a patch graft on the inferior vena cava.
Okay.
Otherwise, we do it ourselves. If you don't have a lot of experience, then it's fine bringing a vascular surgeon in to help with that, especially mobilizing the liver or getting suprahepatic or infradiaphragmatic IVC control.
Okay.
But it's a personal choice.
Then have you had cases where you had to like get the whole inferior vena cava?
Yes.
Like,
and it's not a problem. I think like I showed in the last slide there, or the second to last slide, if you have a lot of vein thrombus or bland thrombus, and you can't, and obviously you can't resect that, and there's very poor flow through that area, then you resect it. Even in the scenario where they have some flow through that area and you ligate the inferior vena cava below the renal hilum,
yes,
the patients will suffer from edema post-operatively, but in the majority of cases, those patients will recollateralize and their swelling will go down. It does take a while for that to occur, somewhere between, somewhere up, it depends on how much flow they had, but up to 3 to 6 months.
All right. Okay. So if we don't have any more questions, I guess you can continue, and then we had some questions at the end of some other tumor, which is not renal cell carcinoma. Wanted just your opinion on how it preferred a case wanted to.
Do you want to start? Do you want to just do that now?
Okay. All right. Let me ask one of the SHOs to summarize the history, and then you can discuss what the approach would be for the patient. Just a second, as a question from Ms. Nasanga.
Okay.
What's your take on lymphadenectomy when you're doing a radical nephrectomy?
Yeah. So as I mentioned, I think the data is very controversial. I think there's no data suggests that there's a survivorship benefit to it. My recommendation is, if you have enlarged lymph nodes at the time of the nephrectomy and they're easy to remove, I would remove them. If they're very difficult and could cause more complications, then I wouldn't. If you're going to do the minimal amount of lymphadenectomy, if you have a left-sided tumor, you could just do the periaortics. If you have a right-sided tumor, you could do the paracavals, and you could consider doing the intra-aortic nodes. But again, recognize that the data would suggest that there's absolutely no real big benefit to it. Okay. It might be if you have a young person, it might there's a potential that you could maybe help a very small minority of these patients. And then the other thing is to recognize is that it may be prognostic. If you have somebody that has positive nodes, most likely they will progress fairly rapidly. If the nodes are negative, which about 60% of the time they will be negative, even if they're enlarged on CT scan, then you at least know that those nodes are just to be observed and don't have to be, and no adjuvant treatment needs to be done. Does that help?
Yes. And any adjuvant therapy that you give after your nephrectomy?
So there are a lot of studies about, you know what? I'll hit this. I can talk about this. I have a couple slides on that, okay? Because we obviously know that about 1/3 of patients that have a nephrectomy will progress with metastatic disease afterwards. And so there are a bunch of studies that have looked at what we call adjuvant treatment afterwards. So normally what they'll get is they'll get a nephrectomy, and then in most of these trials they'll get one of the tyrosine kinase inhibitors, sunitinib, sorafenib, pazopanib, and the problem is that I think I have it right here. All these studies here essentially looked at doing studies where they put placebo versus a treatment arm, and you can see the amount of different kind of drugs that have been used for an adjuvant study. And essentially, if you put all these patients together, the reality is that the benefit, if you look at this slide here, is minimal. Okay, and you have to be careful because obviously these medications have a lot of side effects. So what I will tell you is that in general, we only do adjuvant therapy in the setting of a clinical trial. But for the patient who comes in who's not interested in a clinical trial, we don't advocate using adjuvant therapy.
Is there a role for radiotherapy? Like if you have positive margins?
Yeah.
with a recurrent?
Most of the data will, most of the data does not support that. The most important thing is try to get clean margins surgically. You can certainly radiate. If you have a large, if you, for example, you would have a local recurrence that you see, but we definitely don't. If somebody has a positive margin, we do not radiate afterwards. Okay, that just radiation doesn't seem to be very effective in terms of treating renal cell carcinoma.
Thank you.
Okay. How many cases of kidney cancer do you see in a year?
Yes. About? There are quite many. We don't have the figures here with us, but
you do see a lot. Are they like, how many are metastatic at the time of presentation versus localized?
we have a few localized.
Okay.
Most are advanced, yes.
Okay, mostly are advanced. Okay.
They're going to share some slides of a case that they have.
Okay.
Okay, so can you come and present? Where they? So can you present? Yeah.
Do you see the share button at the bottom of the screen?
Yep. Can you can't start. The other participant is still sharing that we can't.
Okay. Now you should be able to.
Okay. I think you can just share.
Thank you. I'm Dr. Dong Robert, a resident on urology ward. I'll be sharing 9 minutes. Okay. She's a 53-year-old female, a teacher, who presented with 6-month history of leaking urine. And okay. That's the one.
Chris, do you want to end the sharing at the bottom of your screen, just in case that's blocking them from doing so?
Thought I stopped sharing.
Oh, wait, there we go.
Okay. Let's see.
Yeah. 53-year-old female, a teacher,
yeah,
presented with a 6-month history of leaking urine. And prior to that, she had presented 9 months before a diagnosis with vaginal bleeding, and also had lower limb pain, that was on the left, and vaginal discharge with associated low back pain. And then she reported that she had her menopause about a year before the vaginal bleeding started. And at this time when she came in, she had dizziness, headache, and blurring of vision. However, she didn't have any other condition. She's HIV seronegative, and she had been managed for CS cervix. That was stage 2B. This was following histology, which had showed spindle cell carcinoma when they did the histology. and she had been started on radiotherapy.
Okay.
It was not so clear, but she received something between 25 to 40 grays. And our brachytherapy was, so we gave her, she was given external beam radiation. So on examination, she was in a good general condition. The ECOG score was 1 because she was able to do her work. And then she had managed to do the padding well, and you wouldn't even notice that she had maybe leakage of urine or something. A vaginal exam, we noted pooling of urine in the posterior vaginal fornix, and then so we palpated a defect, which was approximately about 3 centimeters. That's the size of the thumb. Other systems were unremarkable. We did a follow-up CT that really showed hydrometra, but also there was some suspicious lesion in the pelvic bone and also involving the lumbar vertebrae. And when we consulted the radiologists, they said it was an osteophyte, so they ruled out metastasis to the pelvic bone. And now the major concern of the discussion is she's a 53-year-old female, still young, and responded well to the radiotherapy with no evidence of local or regional disease. However, we have those suspicious lesions, and now she's a teacher, still able to go and do her work. So our concern is, are we going to do something for her, or are we not going to do something for her to help out with the urine? And in case we decide to divert the urine, our concern is, what options do we have? Are we going to consider maybe the continent pouches, or we are going to just divert to the gut? And then the fact that she had radiotherapy brings in the concern that the gut we may use may not be good enough, because it may break down. And then also we can't rule out metastasis to that gut which we are using. And then the other concern also was, in case we are to do a fistula repair, which we haven't really considered as yet, we really will have an obvious breakdown of the repair. So that's our concern based on the status of the patient, and then the option that we have. That's why we decided to share it with you, so that we could decide. Thank you.
Yeah, a couple questions. How long ago did she have her radiation therapy?
She had radiation therapy in August, about 6 months back. As soon as they diagnosed the CS cervix, they started her on the radiation, external.
All right. And has anybody looked in her bladder yet?
Cystoscopy?
Yeah.
Cystoscopy not yet done.
Yeah. I mean, we're presuming that this is probably a radiation induced fistula, but I think, you know, it's a little early for that, but it certainly can happen. I guess, especially with 25 gray, it seems on the lower aspects of things. So the first thing I would do is make sure somebody does a cystoscopy, and you can kind of get a sense of what the, where obviously the fistula is, and whether or not she's had severe radiation damage to the rest of her bladder. Because if you were to try to repair this, and the rest of her bladder is very, very, very fibrotic or small capacity or been radiated, the likelihood of the repair failing is very high. And so at least on a cystoscopy, you get a sense of what capacity she has and what kind of damage might be there. The other thing I'd want to rule out, and you may is tumor recurrence, and whether you biopsy cystoscopically or she's biopsy transvaginally. I think that's important to rule out. In terms of options for treating this, if her bladder is severely damaged from the radiation, that's a very large fistula, and it's probably unlikely going to heal by primary, closure, and you're probably looking at a diversion. What kind of diversions do you guys do? You do conduits? You do continent catheterizable stomas, or would you?
Yeah. Continent catheterizable stomas, yes, and also males too.
Oh, you do mines too. Okay. Yeah. So I'd be concerned about doing a mines too, because obviously her rectum and sigmoid have probably been radiated.
Yeah.
And I'd be, probably, I think a continent catheterizable stoma would probably be better for her, at least to get the affected ureters and bowel out of the radiation field.
Okay.
But the first thing I would do for sure is make sure that we're dealing with just a radiation issue and not a cancer recurrence issue.
Okay.
Okay.
All right. So our take home, I'm going to go back and do a cystoscopy and take a biopsy, or examine it from transvaginally and take a biopsy. Then, no recurrence, we can consider a continent catheterizable diversion, continent port.
And I think part of it is you need to, when you do the cystoscopy, not only look at the fistula, but look at the rest of the bladder. And if the rest of the bladder has been severely irradiated as well and has a lot of radiation changes, then the thought of salvaging the bladder is, it's not going to work. I would do the continent catheterizable stoma.
All right. So if you found the bladder not badly irradiated, would you consider repairing the fistula?
I think you could. The caveat there I have to admit is that that's a big, if it's 3 centimeters, that's a big fistula.
Yeah.
And that may be very, very difficult to fix long term. If you're presuming all this is radiation, I'd be very surprised if she just got 25 gray. It seems like she got a lot of radiation.
All right.
Okay.
Oh yeah. Yes. All right. Thank you very much, Dr. Chris.
You're welcome. Thank you, guys. If you're interested in any more specific things from, in terms of cancer talks or discussions,
Yes.
Please feel free to let us know. I also have another partner who would be interested in giving some talks. And obviously, I don't know what your needs are in terms of oncology. I heard that you may be interested in a few things with regards to cancer care, and please let us know.
Oh. Yes. We're hoping that you would do also some other cancers like bladder cancer.
Okay.
So maybe in the other sessions we shall have in the future.
Okay. In terms of bladder cancer, what type, what aspect of bladder cancer?
It would be transitional cell mainly. We have a lot of it nowadays. Just the guidelines, how to go about managing these patients.
Okay. All right.
And we had hoped having you visit Uganda, and we do some bit of workshops although we are still in transition, we may not be able to have you as a an oncologist. We still have some resource limitation in regards to space and theater space, and also workability of a workshop right now. So we shall be in touch to communicate when possible you can come in.
Yeah,
And
we can keep that open, and we can talk about that when there's opportunity. No problem.
yes. Yep. So we shall be happy to have you talk about bladder cancers, penile cancers, and also which other ones? And prostate cancer.
Prostate, okay. All right.
Okay.
Okay.
And space them, and we have some challenging cases, so we could maybe do a presentation of about 40 minutes, then we do another one, and we just discuss throughout the whole.
That'd be perfect. Okay. We can certainly arrange that. Okay.
Yeah, otherwise, thank you so much. We appreciate your waking up so early to come and share with us. Renal. Thank you very much.
Okay. You take care. Nice meeting everyone. Okay.
Thank you very much.